Excuse me.
It's just loading. I got an error, but it's just loading now. All right, and we are live on both platforms.
Good morning, everyone, and welcome. I am Jeb Bradley, and I chair the Health and Human Services Committee. Today, we are having a regular meeting of the Health and Human Services Committee for the purpose of conducting public hearings. Before we get started, I will read through a checklist to ensure that the meeting that we are holding is in compliance with the right to know law. As chair of the Health and Human Services Committee, I find that due to the state of emergency declared by the governor as a result of the COVID-19 pandemic and in accordance with the governor's emergency order number 12, pursuant to Executive Order 2020-04 and its extension, this public body is authorized to meet electronically. Please note that there is no physical location to observe and to listen contemporaneously to this meeting, which was authorized pursuant to the governor's emergency order. In accordance with the emergency order, I am confirming that 1, we're providing public access to the meeting by telephone with additional access possible by video and other electronic means. We're utilizing Zoom for this electronic meeting. All members of the committee and selected legislative staff have the ability to communicate contemporaneously in this meeting through this platform, and the public has access to contemporaneously watch and or listen to the meeting on Zoom or YouTube and via phone by following the directions and links provided on the General Court website. We have provided public notice of the necessary information for accessing the meeting in the Senate calendar. We are providing a mechanism for the public to alert the public body during the meeting if there are problems with access. If anyone has a problem, please email remotesenate, all one word, remotesenate@leg.state.nh.us, or you may call 603-271-6931. In the event the public is unable to access the meeting, it will be adjourned and rescheduled. Please note that all votes taken during this meeting shall be done by roll call vote. And finally, let us start the meeting by taking a roll call attendance. When each member states their presence, please also state where they are and if anyone else is in the room with you during this meeting, which is required under the right to know law. And let me also add in the script, toward the beginning, I neglected to say that not only are we meeting today to hold public hearings, but potentially to go into executive session and take action on bills. So I will start with the roll call. Senator Whitley.
Good morning, Senator Whitley here in my house in Hopkinton. My husband is in the house, but I'm alone in the room. And my son is actually at school today. Hallelujah.
Senator Sherman. Tom, you're muted.
Senator Tom Sherman, I am at home in Rye, and my son is in the house, but it is just me in the room.
Senator Gray.
This is Senator Gray. I'm at my home in Rochester, and I'm alone in this room.
Senator Avard.
Senator Avard here in Nashua, New Hampshire, and I'm in my office. We have another person in the house and two loud pets.
And I'm Jeb Bradley. I am in my office in Wolfboro, and I am alone in the room. Okay, so having dispensed with the right to know script, I will open the hearing on Senate Bill 98 and recognize the prime sponsor, Senator Whitley.
Thank you, Mr. Chair, and good morning, members of the committee. For the record, my name is Becky Whitley, and I'm honored to serve New Hampshire Senate District 15, which includes the wonderful communities of Concord, Pennacook, Henniker, Hopkinton, and Warner. I'm honored to bring forth SB 98 today relative to the SNAP incentive program. For folks who don't remember, SNAP is the formerly known as food stamp program. So this bill creates a SNAP incentive program in state statute and allows SNAP shoppers to purchase additional fruits and vegetables by matching their purchases of fresh produce. SNAP incentives lead to a triple win for New Hampshire, including more money flowing into the local economy, health benefits for our most vulnerable populations, and new opportunities for our local farmers. There will be a variety of stakeholders today to speak further to each of these issues. SNAP incentives are already active at dozens of farmers markets and 18 grocery stores throughout New Hampshire via the Granite State Market Match and Double Up Food Bucks, but these are privately funded programs. SB 98 was introduced to show a modest state investment, create infrastructure within state government to be able to draw down additional federal dollars to broaden access to the program for more SNAP recipients. Thank you. I'm happy to take any questions.
Are there questions of Senator Whitley? So I just have one question. I'm looking at the fiscal note, and the bill provides $150,000 general fund appropriation. What would be your anticipation if this were to be approved for this initiative in the future?
I anticipate it being something similar, and we have data to match with the existing programs. But I think other folks behind me can speak to how much how many dollars are used up on the other programs to talk about the predictability of future expense.
Okay.
Thanks.
Are there further questions of Senator Whitley? Okay, seeing none, thank you. And I'm going to have Griffin call the speakers for Senate Bill 98.
All right, our next speaker signed up, wanted to testify, is Alan Reitz.
Go ahead, Mr. Reitz.
Good morning. Thank you, Mr. Chair. Can you hear me fine?
Yep.
Great. Thank you, members of the committee. I'm Alan Reitz, Director of Public and Government Affairs at the Hanover Co-op Food Stores. We have 3 stores in New Hampshire. Our business is the second largest food co-op in the United States, and I am speaking in support of Bill 98. I must admit, it's hard for me to imagine living day to day when every part of life is impacted by scarcity. I have never experienced the lack of food where stretching every dollar was all consuming. Though the portrait of hunger is one I'm not able to describe, I can share what I know of the early success of the Double Up Food Bucks program in our part of New Hampshire. In 2018, the Hanover Co-op became one of the largest Double Up Food Bucks retail locations in New England and New York. The team at our business accepted the challenge of putting this proven initiative into our large operation. Then we saw immediate impact. I'm not talking about impact to our bottom line, but in the lives of people in need who quickly signed up for the program. Sign-up showed a level of need that surprised even us, a New Hampshire business that has sold groceries to people of all income levels since 1936. To date, since we joined the program, SNAP recipients visiting our stores have purchased over $100,000 in fresh produce, yet paid only half that price. New Hampshire needs more retailers around the state to help address the gap we're striving to fill every day. You have the power to extend this program into other local grocery stores. Nashua and Manchester need more coverage. I've learned there's only one Double Up retailer in the Seacoast area. This small request of $150,000 can make progress in those areas. People with limited incomes know the value fresh produce provides. At the Hanover Co-op, we've seen them jump at the chance to eat nutritiously and stretch their budget. Let's use SB 98 to double up state and federal dollars and spread the health. Thank you.
Are there questions of Mr. Reitz? So I just have one question. Can you sort of outline, as the manager of the Hanover Co-op, exactly how this works for your customers? I'm just not sure I'm following from reading the legislation to how an actual customer stretches their grocery dollars.
I can address the question, and if I fail to fill in all the details, I'm happy to follow up with further information. A SNAP recipient is someone who qualifies for those benefits. As some of you know, when a SNAP recipient comes through a grocery line, there's a certain degree of anonymity that must be maintained for privacy's sake. So SNAP recipients first come into our store as qualifying for the Double Up Food Bucks program. They shop for their appropriate purchases under SNAP and the local produce that they buy. Once they go through the checkout line, a card is scanned, so then the system knows that these purchases qualify for Double Up Food Bucks. They receive up to 50% off local produce, for instance, up to $20 a day. So that's an important part of this. So they buy $20 worth of fresh produce, only $10 is coming off their month's supply of money to get through the month. And Granite State Market Match at farmers markets, et cetera, is just such a win for our summer produce season. This time of year, those same customers are able to come into stores like ours and small mom and pops and still continue to find maybe those apples that are available and carrots that we're all enjoying from the past autumn harvest. So I hope that gives you a sense of how it works. What else can I answer for you?
So people have to pre-qualify for this initiative? Is that?
Yes, that is correct. They are SNAP recipients, and this is where I'm getting into the area where it's not my expertise, but this is an initiative that is a partner to the SNAP program that specifically focuses on this nutritious food, healthful food that is fruits and vegetables. The more we can put these on the table, the better.
Okay, so I think the Department of Health and Human Services is going to testify. So those questions of qualification can be asked of them too. Thank you.
You're welcome.
Senator Sherman.
Thank you, Senator Bradley, and thank you for testifying today. You had mentioned mom and pops. This sounds like it's a huge benefit for the farmers co-ops and maybe some of the farm stands and smaller stores. Do you see this as a win for small businesses and for agriculture in New Hampshire itself?
I do. We've seen it work that way, but when we also say small mom and pops, these are the independent grocers who are a vital part of our small and medium-sized towns. So I think we've seen it be successful in our larger store, and my involvement and awareness of this has proven that we're not alone in trying to fill this gap. When it comes to agriculture, New Hampshire has a vibrant agricultural sector. We're very fortunate, and I'll make one last point. During the time of COVID, I can tell you as a retailer, when there were shortages across the food shed we heard about on the national news, stores like ours and the small food sector that we all depend on was critical in this time of COVID to get food to people who needed it.
Senator Sherman, another?
No, that was it. And thank you so much.
You're welcome. Thank you.
Any further questions of Mr. Reitz? I used to own a natural food store myself back in the day.
You know the challenges of being in the grocery business then.
Yeah, I do. Okay, Griffin.
So our next person is Brendan Cornell. Bring him in now.
Hello, can you hear me?
Yep.
All right. Chairman Bradley and members of the committee, thank you for allowing me time to speak today. My name is Brendan Cornwell, and I coordinate the Granite State Market Match program. Granite State Market Match offers SNAP incentives at direct-to-consumer venues throughout the state, focusing mainly on farmers markets, farm stands, and community-supported agriculture. I am in support of SB 98 relative to the SNAP incentive program. These programs allow for SNAP recipients to receive a $1 match on fresh fruits and vegetables at grocery stores and farmers markets. This gives New Hampshire farmers an opportunity to access federal SNAP dollars, which traditionally are spent on food produced either outside of New Hampshire or in many cases grown outside of the US. In 2011, we started offering SNAP incentives at 3 farmers markets. Now, SNAP incentives are offered at 49 direct-to-consumer venues and 18 independent retailers, increasing access to fresh fruits and vegetables to SNAP customers throughout the state. This number of venues grows monthly, with more farm stands and markets signing on. In 2020, the use of Granite State Market Match Incentive Program increased 22%. This increase is consistent across every county in the state. Over 3,000 SNAP households utilize the program to purchase fresh New Hampshire grown fruits and vegetables. I know firsthand the positive and important impacts of this program on the health and well-being of New Hampshire families. As an example, a SNAP customer from the North Country expressed, "It has been a struggle to fulfill the need for fresh produce on a shoestring budget. Words cannot express my gratitude for the Market Match program that is now provided to SNAP customers like me. It has really changed my life in such a positive way." End quote. I have collected data from farmers markets from farmers at the end of markets that have had 10% of their daily sales be SNAP and incentives, making it possible for them to hire another employee and continuing the chain of local spending and investment. In the past year, when shutdowns changed everything, I worked with farmers across the state to set them up to accept SNAP. It is important to New Hampshire farmers to be able to offer these important programs to their local community. This is important to New Hampshire because it makes healthy food more accessible for families, gives New Hampshire farmers an additional customers, and boosts the local economy. The positive impacts of these programs are even more critical given the challenges of COVID-19, and I urge the committee to recommend SB 98 to pass. I can answer any questions you have about Granite State Market Match or the Double Up Food Bucks program. I'm happy to answer them, and I have also submitted written documents to the committee that contain my contact information if you have further questions. Please feel free to reach out. Thank you.
Thank you very much, Mr. Cornwall. Are there questions of Mr. Cornwall? Okay, seeing none. Griffin.
See, our next person we have signed up, I believe, is Morgan Morani. I'm sorry if I butchered that last name. One second.
Hello, can you hear me?
Yes, good morning, Ms. Morani.
Good morning. My name, like you said, is Morgan Morani. I'm the program coordinator at Seacoast Eat Local. We're a nonprofit out of Dover, New Hampshire that operates farmers markets in the winter and operates a SNAP program at farmers markets on the Seacoast and farm stands. Today, I'm on here to give a little bit of testimony and a little bit of my experience with a SNAP shopper this past year. At one of our farmers markets this past year, I had a SNAP shopper come up to the table. I had never seen her before, so I knew she was a new customer. She mentioned that she had heard we accepted SNAP at the farmers market, and she had her EBT card with her and wanted to hear about the program. I continued to tell her about how Granite State Market Match was able to offer a 1-to-1 match on her funds via fruit and vegetable coupons. I could tell her story wasn't done, so after she charged her card, I offered to give her a tour around the farmers market. As we walked around, I could tell that her emotions were swelling and she was about to cry, so we stepped to the side. And she told me that without this program, for a while now, she hadn't been able to afford fresh fruits and vegetables for her family. She continued to tell me how she used to love to cook and how this year had given such a great impact on her ability to provide meals for her family. She still continued to cry as I walked her through the farmer's market. She made a few purchases and mentioned that she would be back. To this day, I see her at almost every one of our farmer's markets. She gives me a brief smile, but I can tell how Granite State Market Match has impacted her life and the lives of her family, because here and there she'll stop by and let me know about the recipes that she's been able to put together for her family, because for a while she could only afford cans of vegetables or just small purchases at the local grocery store. Knowing that these incentives are available to her and her family has impacted her life greatly, along with the lives of many SNAP shoppers. I urge the committee to pass SB 98. And if you have any questions, feel free to reach out or ask me now.
Are there questions of Ms. Marani? So just one quickly, for this SNAP incentive program to work at a farmer's market, the market has to be able, or the vendor, to accept the EBT card. Is that correct?
Yes, and we do have terminals at these farmers markets along with farm stands that enable that as well. And the way that we offer the incentives is through a fruit and vegetable coupon that can then be used with local farmers.
Okay. Okay. Thank you. Any further questions? Seeing none. Griffin.
Next up is Rebecca from New Futures.
Hi, can you hear me all right?
Yep. Good morning, Rebecca.
Good morning. Thank you for allowing me to testify today. My name is Rebecca Wojtkowski, and I'm the Kids Count Policy Coordinator at New Futures. New Futures is a nonprofit, nonpartisan organization that advocates, educates, and collaborates to improve the health and wellness of all New Hampshire's residents. And my work focuses solely on how we help kids and families. So we stand in strong support of Senate Bill 98 as it aims to increase access to healthy fruits and vegetables to our most vulnerable children and families. Research has shown that the impacts of certain adversity, including poverty and early childhood, negatively impacts lifelong health outcomes and increases overall state costs. As Senator Whitley mentioned in the beginning, there's a triple win for our state, and I want to just go over a couple of those points. So incentive programs allow recipients to receive a dollar-for-dollar match on fresh fruits and vegetables at participating grocery stores and farmers markets. Because of this, families have access to nutritious foods that would otherwise be out of reach for them. And you heard that from Morgan. Clearly, this is a health benefit. SNAP incentive programs also foster a sense of community and relationship with local producers and grocers that have positive impacts that ripple out beyond food and nutrition. This is clearly a life and community benefit. And you heard that from Alan Reitz and talking about how they were able to help families when grocery stores didn't have very much during the beginning of the pandemic. And lastly, the focus on local fruits and vegetables gives an economic boost to local farmers and the economy, and particularly small business as well. And that's vitally important for our state, especially now. So that's the healthy triple bottom line that you'll hear. And I want to emphasize again, we all know that COVID-19 has placed insurmountable burdens on families right now. So I really encourage you to consider how this modest state investment can really help residents and families in our state. I want to make one point because I think that the other advocates have really crossed over the details of the programs, but included with my testimony are over 20 letters of support from participants, retailers, farmers, business owners, and advocates across the state. These are local New Hampshire residents. I encourage the committee to read all of the included letters because they are a powerful statement of support, of local support for this bill. So on behalf of New Futures and all of those who allowed me to submit their letters of support today, we urge you to vote Senate Bill 98 ought to pass. And I want to, if I could, go back to a question, Senator Bradley, that you posed to Senator Whitley around looking at future costs of this bill. The one key item that I think the committee should consider is that the programs are limited by funding. So if the state were to approve the appropriation included in this bill of $150,000, the programs can't go beyond that, with the exception of getting that in potential federal state match. So in some, it could be a $300 investment to the state, but it's not a program that grows by the number of participants. It grows by the amount of the appropriation. And to put this in a little bit of context, Massachusetts puts $8 million a year into their SNAP incentive programs. Maine has just started a SNAP incentive program, and there's one in Vermont. So it is in line with what is going on regionally, but this is a very modest start into this program. And I'll take any other questions you may have.
Senator Sherman.
Thank you, Senator Bradley, and thank you for your testimony. we're right in the middle of COVID. We are in a budget crunch, but we also are trying to make sure that our small businesses and growers are whole. Can you just comment on the financial benefit to businesses and agriculture, especially in COVID?
Sure. I'm not a retailer, but I'll say there's a positive economic benefit. There is also the potential for the state, if we choose not to do this, to lose an opportunity to access federal drawdown. So in the second stimulus bill, there's $75 million that is appropriated just to SNAP incentive programs. Now, we could potentially receive some of that if the programs that are currently operating were able to fundraise a bunch of additional private dollars. But on the federal level, they're really looking at states that have built or have existing infrastructure to draw down those dollars. And right now it's a 50-50 match, but looking forward, because these programs are so well received and bipartisan support across the country, there might be opportunity for different ways to bring SNAP incentive dollars to the state. And if we don't have infrastructure, we can't access that. And as you said, Senator Sherman, that brings dollars right down to our farmers markets, our farmers, and our small grocers and retailers.
Further?
Follow up?
Yep.
You just said something that this may be a question actually for Senator Bradley, but it's really, I'll direct it towards you. Right now we're talking about $150,000 general fund allocation. But do you think it would be smart for us to make sure that this line item or this fund can accept charitable donation and also federal funding without any speed bumps?
I think that and any way in which this line item could receive additional federal funds without speed bump would be great. I believe that the organizations Double Up Food Bucks and Granite State Market Match already receive the charitable dollars, and we have worked in close coordination with our state partners here to figure out how to streamline the process so as not to create administrative burden and costs for the state, understanding that we are in the economic times that we are. So I don't know that the being able to include charitable dollars in this line in the budget makes sense. I think that's taken care of with the infrastructure that already exists. But in any way that additional federal funds could come down to support these programs would be a smart way to structure this line item.
I think, Senator Sherman, that's a question that could be asked of the department, and they're slated to testify. Senator Whitley?
Yes, thank you, Mr. Chair, and thank you, Rebecca, for your testimony and all your work on behalf of New Hampshire children and families. So this might be a question for other folks, but do you have a sense of how much of the federal stimulus could come to New Hampshire for SNAP incentives?
Well, right now we're in an opportunity to which there's a lot of national lobbying going on. So we are working with local advocates to indicate what will be best for our state. And a key to that is going to be showing need and state interest in expanding programs across the state.
Further?
Yep, just a follow-up. So when you say showing state need and interest, do you think a bill like this that shows that we have state level infrastructure would demonstrate to the feds that need and that interest?
Yes, it absolutely would. And I'll just make one more comment. We have been working as a coalition around how to increase access to these programs for a couple of years now. And I have been approached by other large philanthropy organizations that were interested in could possibly contributing to the state, but have not done so because the state didn't have a formal structure or bill around supporting these programs. So there are some missed opportunities that I would like to not miss again.
Thank you.
Seeing no further questions, thank you very much, Rebecca. Griffin.
Next speaker we have is Tiffany from, I believe, the New Hampshire Public Health Association.
Good morning. How are you?
Good morning. I'm well. How are you, Chairman?
Good.
Great. Thank you for giving me the time to speak. My name is Tiffany Dodier. I am a registered dietitian speaking on behalf of the New Hampshire Public Health Association, which is a statewide membership organization composed of healthcare and public health professionals. For the last 25 years, we have advocated for policies that improve the health of New Hampshire's people. Today, we submit this testimony on behalf of our members and partners to state our strong support for SB 98 relative to the SNAP incentive program. We strongly believe that passage of this bill will provide families in the SNAP program with the opportunity to purchase additional healthy fruits and vegetables, which will contribute to better nutrition and overall health. Since the outset of the pandemic, I have volunteered and worked in task forces and coalitions that have desperately tried to figure out how to feed those that have fallen on hard times in New Hampshire. Those needing this emergency assistance for perhaps the first time in their entire lives find themselves feeding canned beans, white rice, white bread, and maybe some canned corn or green beans to their hungry families. So there's an awful lot of white and gray things in this list, typically, typical food pantry staples, right? But hunger is not always the issue. The things like IQ, immunity, child behavior, and meeting those infant milestones that every mother obsesses about are just a few of the things affected by diet quality. When I talk about diet quality, it's really about how well your diet can nourish your body or the amount of nutrients that you can consume in your food every day. We've all been told the importance of fruits and vegetables in our diet to provide important vitamins and minerals, but nutrition research is booming with new studies about antioxidants and phytochemicals and all these other beneficial compounds found in fruits and vegetables that we have yet to even discover. Mounds of research show the protective effect of fruits and vegetables from the risk of death for a plethora of diseases. As the number of servings goes up, the number of deaths goes down. In fact, an estimated 100,000 deaths occur from eating too few fruits and vegetables every year. Study after study in cities across America show an increase in servings of fruits and vegetables by SNAP incentive participants, some by as many as 5 servings per day. On top of more healthy food for Granite Staters, this bill betters business for farmers and boosts the local economy. Passing this bill will strengthen the nutrition part of the Supplemental Nutrition Assistance Program while making our federal SNAP dollars go further and work harder. For these reasons, and on behalf of the members of the NHPHA, I urge the committee to recommend SB 98 ought to pass, and I'm happy to answer any questions you have to health benefits and effectiveness of the program to improve diet quality.
Thank you very much. Are there questions of Ms. Dodier? Seeing none, I think we have one more person to testify before the department. So go ahead, Griffin.
Yep. So our next person is Jess Guerrier. I hope I'm saying that last name correctly.
You have. Can you hear me?
Yep.
Good morning.
Thank you so much. I am an independent mother of 3. I'm a graduate student. I'm an adjunct instructor, and I've used food assistance for most of my children's lives to be able to support them to have a healthy life. I really want to thank the grocers and the co-ops and the farmers markets whose staff have piloted these programs and advocated for it. And I want to explain that when a person finds themselves with low means, despite their best efforts, it means having to choose between cheap goods that come from far away, aren't as healthy for their families, and don't add anything to local business or the community, or to have real food that comes from New Hampshire but isn't financially accessible. Programs like this create choice because the farmers and local businesses want to sell to everyone, not just the financially advantaged. COVID has brought to light the ways that our industrial food system is unstable, unjust, and unsustainable. And programs like this have the potential to make New Hampshire not only responsive to that, but resilient. And I want to thank you for your time.
Are there questions of Ms. Guerrier? Seeing none. Thank you very much. Okay, so now I believe we have the Department of Health and Human Services.
Correct. I will bring up Molly Lynch. And I also did see that Maureen Burke was also signed up on behalf of the department as well, but I'll let Molly sort it out.
Thank you. Good morning. My name is Molly Lynch, and I am an attorney and legislative liaison with the New Hampshire Department of Health and Human Services. And the department is neutral on this bill, but we're happy to, answer any questions. And Griffin, as you mentioned, I'm also here along with Maureen Burke, who can you unmute her as well?
Yep, 1 second.
Good morning, committee members. My name is Maureen Burke, and I am the New Hampshire SNAP Administrator.
Are there questions of Ms. Lynch or Ms. Burke? Yes, Senator Sherman.
So I'll ask my question now that I asked earlier. In several bills that have an allocation in many different departments, we have written into statute that they may accept private donations or federal dollars. And so this is a two-part question. The first part is, do we need to add that to this so we can maximize the funding in this line item? And is maximizing the funding in this line item critical to being able to accept federal dollars, especially if it's a 50-50 match? So do we need to modify the bill to make sure that it can accept private and federal funding? And is it helpful to have all of that funding, private and federal and state, all in one account, if you will, or line item, so that the federal match can see that as the amount that they would be matching? Thanks.
Well, I think in drafting the fiscal note, we assumed that we would be doing an RFA with the 150 and in reviewing applicants and awarding it to a successful applicant if they, we would create objective criteria for them to, and if they met those criteria, we would do the 150,000 appropriation, and then that would be matched with the federal funds. Maureen, do you know how that would work? How the department would?
Yeah, it's my understanding that the SNAP incentive programs would be participating in a Gus Schumacher Nutrition Incentive Program grant. So my understanding is the organization would have to be a recipient of this grant. And the organization would be applying for this grant, which is a joint effort of the National Institute of Food and Agriculture and the Food and Nutrition Service. So once the organization receives this grant, then they can receive the federal matching funds. So we would, through our RFA process, require that the organization has a GusNIP grant.
By organization, you mean the retailer?
Meaning the Granite State Market Match or Double Up Food Bucks program, that they would be the organizations that apply for the funding.
Okay.
Mm-hmm.
And according to the fiscal note, it would appear that you already have some of these SNAP incentive programs in New Hampshire. So there must be the ability to accept private funding. To go back to Senator Sherman's question, it would appear that way.
So the programs themselves would be the recipients of the private funding. So the Double Up Food Bucks or Granite State Market Match, they would be the recipients of the private funding, which that funding could also be matched with federal dollars. So they can get a match for federal funds either with our state allocation or with their private fundraising.
So I think, and maybe Senator Sherman has the same question, but there would be no need for an amendment to allow acceptance of private or charitable donations.
I don't believe the state would be in that role to do that.
Okay. Senator Sherman.
Just a quick question. What would be the impact then if we did not do the $150,000 allocation?
Well, the $150,000 allocation will be matched. So that would be $300,000 available to these programs in the state. Without the program, what I really like about the program is the focus on the fresh fruits and vegetables and the local economy. So it really does encourage participants to buy fresh fruits and vegetables. And especially now during the pandemic, availability of healthy foods, is a great health concern.
Go ahead, Senator Sherman.
Yes, one last question. You sort of touched on it, but we are looking for mechanisms to support both people and our small businesses in the pandemic. That really we know where the dollars are going. We just giving blanket grants to people. We've talked about this ad nauseum in the legislature, how we target those dollars. Is there, do you have any idea of how much need there is in New Hampshire? If we were to allocate more than $150,000 to a program that both supports our businesses as well as people in need, do we know how much? We heard that Massachusetts is doing 8 million. Of course, we're not going to do that, but 150,000 is relatively a small amount given our total budget.
Well, I can say that we have 70,222 SNAP recipients as of December 30th. This program would be made available to all recipients in the program. So it is statewide availability to that many individuals.
So you're saying that our allocation is basically $2 per recipient, a little bit more than $2 per recipient of state dollars.
That sounds about right.
Senator Whitley.
Thank you, Mr. Chair, and thank you, Maureen and Molly. Just sort of to clarify the state infrastructure. So the way that you read the bill, that it's not providing additional burdens on the state other than creating the RFP for the money to be, to go out into the community, correct?
That is correct.
Okay, thank you. And in terms of receiving federal dollars, I'm unclear. I don't know if you can answer this or someone else. Are the federal dollars coming in through the relief program specifically for the SNAP incentive program or for the SNAP program at large?
Yeah, I really cannot answer that at this time. The relief funds, how they will be coming in.
Okay, there might be someone on the call that can raise their hand and answer that question. Thanks, Maureen, I appreciate it.
Further questions? Okay, so I have a couple. If we were to allocate 150,000, it's matched by the federal government and it's $300,000, what happens to a program recipient getting the 50% discount, if you will, on fruit and vegetables when that $300,000 runs out? Either one of you.
Maureen, my understanding is that, there would still be private funds raised for the SNAP incentive programs because the programs are currently operating now. There's either 2 or 3 of these programs operating in the state. So I would presume that if the $300,000 runs out, the programs would probably still be in existence because there is still private funding and donations. Would you agree with that, Maureen?
Yes.
And my other question, do we currently have any of these SNAP incentive programs for items other than fruit and vegetables?
Not to my knowledge, no. The focus
So-
is on fruits and vegetables with
So the
the,
existing programs focus on fruit and vegetables.
yes.
Okay. And would there be other food items that could potentially be eligible? I'm just curious.
Not to my knowledge, it's a requirement of the Gus NIP.
The Gus
grant
grants. Okay.
That
All
it
right.
focuses on fruits and vegetables.
Okay. Any other questions of the department? Seeing none, thank you both very much. Griffin, we may have had a couple of hands go up. We are somewhat late, so quickly, if there are people that wish to testify.
Sure. I will bring in Jessica Margison.
Thank you very much. I apologize for joining late and I'll keep it quick. I think something very important to bring up is my daughter has severe celiacs. This would be very beneficial for us. This year she had to have 4 infusions because her anemia was so bad. When someone with celiacs is not eating properly, the stomach deteriorates to a point they cannot absorb food properly and get their nutrition, making them incredibly ill. She was in the hospital for over a month, 4 infusions, and it took that to get her stomach healed and to be able to eat and everything. I am on food stamps. I have a limited income. It's set with my disability and my kid survivors benefits. We don't have room outside of that. Recently, with how everything increased, we actually lost our food stamps. So I had to try and improve all of our transportation. It just puts families at a horrible situation between choosing food that's good for them, that they need to actually do better, which will save way more money in many other departments that the state spends money on healthcare wise, just to get the proper nutrition. And I hope someday it can include more, as Senator Bradley mentioned, the possibility of more being included, such as the 5 main food groups. And it would be great, but just to get fruits and vegetables, which occupy 50% of her plate every day, would be a huge increase in what's needed. Thank you.
Thank you, Ms. Margison. Questions? Thank you. Thank you very much. Griffin?
Next person we have is Liz Alpern.
Good morning, Ms. Alpern.
Good morning, and thank you for letting me join today. My name is Liz Alpern, and I have been administering the Double Up Food Bucks program here in New Hampshire since 2017. I just wanted to clarify a couple of points that have come up on this discussion. First, to say that we are indeed actively raising private funds for this program. And with the Gus NIP application, we are planning to apply for the match using some of those private funds as well. So the state funding would be an incredible resource to draw down those federal dollars. But just, it's not the only source of funds. And I wanted to clarify that. And I wanted to add that I think this program right now, we estimate reached around these 2 programs last year reached around 8,000 New Hampshire families. Essentially we feel that this program there's so much more need than those 8,000 families, that this program could actually reach many more thousands of families. And so our hope and our goal is to grow this program in such a way over time that we can continue to contribute to the nutrition that families are receiving through the SNAP program and enhancing their access to local produce. And I just wanted to add one more thing. If you review some of those letters of support, we do have some letters from some of the local businesses that participate in this program. And they really see a huge impact, both in increased enthusiasm from shoppers and goodwill from shoppers, but also just increased spending, increased produce purchasing. And so store owners really see this as a no-brainer, especially our local independent stores that are struggling to stay afloat in some of the smaller cities and towns across the state. So I look forward to sharing more of those stories with you from some of our store owners. Thank you.
Thank you very much, Ms. Alpern. Senator Sherman, question.
Yeah, a quick question. Actually, it's two-part. One is about how big is your budget right now using just private funds? Second is are you applying for federal match for those private funds? And third question is, do you have, are you doing active marketing so that you can increase, if there are 70,220 plus eligible recipients, and we're only hitting about 8,000, it sounds like there's a bit of a challenge to reach more and expand that. Is there an active marketing plan to broaden the net, the umbrella?
Yep. Thank you for those questions. First, around the marketing, absolutely. One of the hallmarks of these programs is that we do a ton of outreach in the community, between flyering through all the food pantries and outlets to ads on social media. And it's actually 8,000 families that have participated. And so that generally is around 2 to 3 people per household. So it's a little bit more than 8,000 people. But in terms of the application, so the New Hampshire Food Bank is the body that holds Granite State Market Match, and Granite State Market Match and New Hampshire Food Bank will be applying for the GusSNP this year, for that federal match this year. The application is actually due this March, but there's some in-between time after the application. So that application is happening right now, and we're in the process of raising those federal funds. And the last application was submitted in late 2017, early 2018. And just as a sense of scale, just in 2020, the private funds allowed for around $95,000 in Granite State Market Match to be redeemed, and $130,000 at grocery stores. So that's around $225,000 just in redemptions, just in use of these programs. And that gets doubled when you look at the SNAP dollars that were paid on top of that. So that's been the scope just in 1 year with the private dollars.
Great. Thank you very much, Ms. Alpern.
The last person wanting to testify is Rebecca from New Futures for a second time. I will bring her in.
Can you hear me?
Yes.
Yep.
Okay, great. I just wanted to clarify a question that Senator Sherman had around the amount of the appropriation. And I really want to emphasize that this group acknowledges that that appropriation does not, even with the federal match, would not mean that every SNAP participant could fully utilize the SNAP incentive program. But instead, we came together to look at utilization data, what has been trending for private funds, some risk around continued contribution by philanthropy, to make a conservative request based on what we thought for growth and full utilization. It is not everything that I think that we could potentially need to serve our entire state, but I just want to emphasize that the reason it is $150,000 is because we went through a thought process of being very careful about what everyone thought that we could use to reach more families. So of course, I think that the advocates would be interested if there was an increase in appropriation, but I want to make sure that it is acknowledged that that number didn't come out of anywhere. It was really a thought process to be conservative with what we were requesting.
Okay. Thank you very much. Is there anybody else who has not had an opportunity to speak? They should raise their hand. I don't see Griffin indicating. In that case, let's close the hearing on Senate Bill 98. And if we can move to open the hearing on Senate Bill 97.
Nope. Sorry, Senator, I think I muted you. You're good.
Thank you. Good morning, Senator Bradley and other senators on the committee. My name is Erin Hennessy, and I represent Senate District 1, and I am the prime sponsor of both parts of Omnibus Bill, Senate Bill 97. So I'll go part by part for you. Part 1 deals with direct primary care providers and will allow direct referral to medical specialists without having to require the patient to see an additional primary care provider first. It also simplifies the process for patients and takes some of the cost out of the system. Dr. Eric Kropp, a direct primary care provider and the president-elect of the New Hampshire Medical Society, is on the line today to explain this bill further and to answer any questions you may have about it. And then part 2 deals with in-network retail pharmacies. During the pandemic times, it really has given rise to the need for consumers to shop in alternative ways, from curbside pickup to delivery to mail order. And this bill would prohibit pharmacy benefit managers from restricting in-network pharmacies from mailing or delivering prescriptions, and would allow patients to access their medicine in a way that they are comfortable with. David Rochford, a pharmacist and pharmacy board member, is on the line amongst others to explain this portion of the bill further. I am happy to take easy questions.
All right. Are there questions of Senator Hennessy? Okay.
Thank you very much.
Seeing none, thank you very much.
Our next because the bill's relatively short, Senator, I figure I just go by the sign-in sheet rather than by.
That's fine. Yeah, yeah, that's fine.
I will bring in Representative Bill Marsh.
Good morning, Senators. Can you hear me?
Yep. Good morning, Representative Marsh.
Thank you for this morning. I want to thank Senator Hennessy for including our direct primary care bill in her bill here. For the record, I'm Representative William Marsh, representing Carroll 8, 7 towns in Southern Carroll County. Section 1 of this bill regards referrals from direct primary care providers, and that's what I intend to speak to. As you know, last session we passed my bill, House Bill 508, allowing direct primary care in New Hampshire and establishing that it was not insurance. People who utilize direct primary care are encouraged to continue insurance coverage, as primary care physicians cannot address every medical need. Unfortunately, this puts direct primary care providers at a significant disadvantage compared to other providers, as insurers do not allow them to make referrals to specialists or for various tests. Patients have to see a second provider for referrals. This duplication obviously increased healthcare costs. Maine addressed this subject in 2019 by adopting SB 372. This bill adopts similar language in New Hampshire so that New Hampshire direct primary care providers fully compliant with RSA 329(1)E are no longer at a competitive disadvantage. I also support Section 2 of the bill, but I'm not prepared to speak on it. I thank you, and I'll be glad to take questions.
Are there questions of Representative Marsh? Senator Sherman.
Good morning, Representative Marsh. Thank you. I think you have a similar bill over in the House, if I'm correct. The question I have is, we have seen in New Hampshire a practice among some large hospital systems of requiring orders. For example, an abdominal ultrasound order has to come from one of their physicians. So it really is broader than direct primary care. They're requiring an in-network order. So it kind of clobbers the independent practice physician in the community who wants to order that abdominal ultrasound, doesn't have the capacity to do it except at the local hospital. The local hospital is owned by a larger system that requires those orders come from somebody with privileges at the hospital. Does this address that at all, or is this really limited to direct primary care?
Thank you, Senator. I appreciate the question. We do not have a parallel bill to this in the House, so this is the only opportunity to bring this forward in this session. You are perfectly correct. There's a great many barriers to independent private practice. And in fact, people who were individual practitioners, as I was, have become dinosaurs. And you're perfectly correct that one of the barriers is institutions that require only their employees to utilize their resources. And I agree with you that very well be an anti-competitive problem. On the other hand, this bill specifically addresses insurers. It does not mandate that hospitals make use of other physicians in communities. And as a hospital trustee, I can say that there would be considerable pushback towards such a bill were you to bring such an amendment forward. So I would ask that this not be used as a vehicle for that.
Senator Sherman.
I promise I won't do that. But will direct primary care providers run into that same snafu if this does not address that? If this is addressing only insurers, will they still be potentially running into the hospital-based roadblock of you have to have the orders come from one of our providers?
Certainly, and physicians who practice in one hospital will reach a similar roadblock if they want to order tests for a patient who happens to be living in a community where another hospital may provide services. So this is not a unique issue, and I think that's a very complex problem. But you're correct. Yes, it would continue to happen.
Further questions of Dr. Marsh, Representative Marsh, sorry. Okay, seeing none. Griffin.
Thank you. Next person we have is Richard Cohen from, I believe, the New Hampshire Pharmacists Association.
Good morning. Can you all hear me?
Yes.
Thank you.
Go ahead, sir.
Good morning, Chairman Bradley and members of the committee. My name is Richard Cohen. I am currently retired pharmacist. I practiced my profession in community pharmacy for more than 45 years. The past 12 of those years here in New Hampshire. Actually, before I retired in 2018, I was the pharmacy manager at Colonial Village Pharmacy in Kentucook, Senator Whitley's district. Throughout my career, I have served on many committees and boards, which were committed to the promotion and advancement of the practice of pharmacy. I served as president of the Connecticut Pharmacists Association, and I currently serve on the executive board of the New Hampshire Pharmacists Association. I'm here today to testify in support of SB 97 for the association, specifically the section on pharmacy benefit managers, PBMs. In 2018, I served on the committee to study the impact of pharmacy benefit manager operations on cost, administration, and distribution of prescription drugs. This committee discussed pharmacy relationships relative to pharmacy benefit managers' business practices, licensure, and transparency. I believe that was SB 481. Independent pharmacies in New Hampshire have long sought a level playing field when entering into agreements with pharmacy benefit managers. The major PBM players all have a mail order segment to their operation, and according to their contracts, have prohibited pharmacies from mailing or delivering prescriptions to their clients. Why? Because by doing so, they can control, retain, and increase their patient market share. SB 97 will create a level playing field with respect to this matter. It will protect in-network pharmacies from being penalized by being charged additional or erroneous fees for the actions listed in the bill. Most importantly, it will protect the consumer who is enrolled in a network managed by a PBM from being penalized or assessed additional charges or co-payments for utilizing the local services of their neighborhood pharmacy. In closing, I ask you to find SB 97 ought to pass, and I thank you for your consideration.
Are there questions of Mr. Cohen? Yes, Senator Avard.
Thank you, Mr. Cohen, for your testimony. So in essence, this basically creates when you say a level playing field, it creates competition in the market for to lower prices.
Yes, it does.
Thank you.
Further questions? Seeing none.
Next person we have is Samuel McCready.
Good morning, Mr. McCready.
Good morning. Can you hear me?
Yes.
Okay. Well, thank you, Chairman Bradley and members of the committee. My name is Samuel McCready. I am a family physician, currently living and practicing in Gorham, New Hampshire. My wife and I moved up here in 2016. We had visited the area and kind of fell in love with New Hampshire and decided to make it our new home. When we moved here, I took a job as an employed physician at a large federally qualified community health center and worked for that community health center until July of this past year. At that time, I decided that the current insurance system and the barriers to care that it created through administrative burdens, et cetera, really just made it very hard for me to deliver the type of care to my patients that I felt they deserved. And so I was toying with the idea of going out on my own and trying to create a better healthcare experience for my patients. I was very encouraged by direct primary care and my observations of it around the country and communications with other physicians and patients who have experienced that. And I thought, I'm going to give this a shot. And so a few months ago, I went ahead and launched a direct primary care practice of my own. It's a very early launch. And so I don't have a whole lot of patients. And so frankly, the stuff that's going on that's addressed in this bill with the limitations on orders and referrals have not directly affected me or my patients as of yet. However, it is a big issue nationwide, and there are other direct primary care doctors in this state who have been doing this longer than I have, who can, I assume, comment on this a little bit better. In a nutshell, the issue here is that if you are in particularly an HMO insurance plan, those plans typically have network providers and they restrict care to those network providers. On the surface, this seems reasonable. You know, they're trying to lower their costs and they maintain a network of primary care physicians and hospitals, et cetera. The problem comes in if a patient chooses to see a direct primary care provider for their primary care. Well, now we have this system where in order to get referrals or orders for things like MRIs and x-rays and stuff, there's a potential that the HMO says, well, we're not going to accept the referral or accept that order from a direct primary care physician because he's not in our network. So what the patient ends up having to do is now go make a second appointment with another provider who is in a network just to get the orders reissued. This adds cost, it adds burden, it makes things much less accessible to patients. Up until July, as I mentioned, I was working for a federally qualified community health center. The clinic I worked at is about a mile from my house. While I was in that clinic, there were numerous mid-level providers, physician's assistants, nurse practitioners who I worked with and supervised. And it seems kind of silly to me that if I see a patient who chooses to follow me and maintain their relationship with me as their PCP, it seems somewhat silly that if I wish to have them seen by a specialist, such as a cardiologist, and I say, hey, let me send a referral, they now have to go make an appointment and see potentially somebody I was supervising a few months ago to get my order basically reissued. It's a waste of time. It's a waste of resources. It's really an unnecessary burden on the citizens of New Hampshire who happen to be in HMOs. One point that has been made previously when I've discussed this issue with others was, well, gosh, you know, the people don't have to be in an HMO. Well, the reality is that's easier said than done. A huge percentage of our population doesn't really have much say in what insurance plan they're in. They get it from their employer, and if their employer, you know, puts them in an HMO, that's what they're in. Until I left the federally qualified community health center where I was working, that was my situation. I was insured by a large HMO. When I left the community health center, one of the first things I had to do was establish insurance for myself. My wife and I consulted with an insurance broker, and the insurance broker basically came back with a collection of plans that he recommended. Every single one of them was an HMO. He told us, you might actually be better off just sticking with the COBRA on your current HMO. Well, the cost for that was astronomical. I decided to look at the healthcare.gov marketplace. And on that marketplace, there was basically two types of plans available, HMOs and EPOs. at the time, this is back in, I guess, July, at the time, I didn't actually know what an EPO was. Now, I'm a physician working in the healthcare industry, and this stuff confuses me. I can only imagine what somebody who's working as a hairdresser or a car mechanic or whatever goes through when they're in this process. But at the time, the EPOs were all offered by company Ambetter, and my impression at that time was that Ambetter was basically the company that was managing the Medicaid system. So I did not even think I qualified for these EPOs. I've since learned that I have. Ultimately, my wife and I enrolled in an HMO, and then this January, this last month when it was time to do the new enrollment, we did get into an EPO, which is an exclusive provider organization. But the bottom line is that a PPO, which is something that really allows patients to have a little bit more personal freedom in who they choose to go to for their primary care, PPO is not even an option on the entirety of the healthcare.gov marketplace. When I looked at that actually yesterday, as I was preparing for this talk, just to make sure that I was looking at it correctly, I checked through the healthcare.gov marketplace for every county in the state of New Hampshire, and there was not a PPO plan available on the marketplace. So there's an awful lot of people who are basically in HMOs by default, whether they want to be or not. And those patients now, if they say, hey, I really want to go see this doctor who's a direct primary care doctor, this is somebody I know and I trust, and I want to put my healthcare in their hands, well, they've got the choice of either foregoing that relationship or recognizing that if they have that relationship and they want to maintain that doctor as their PCP, they're also going to have to maintain a secondary sort of pseudo PCP who exists strictly to reissue orders that their primary PCP has issued. It's wasteful. There's really no benefit to this restriction on access and care. And I would basically just encourage the committee to support this bill. I see really no downside to it.
Senator Gray, can you take over for a minute? I think somebody's at my door.
Done. Do we have questions? Senator Avard, unmute.
Thank you, Mr. Chair. I just, years ago, we used to, when the HMOs were introduced, it was supposed to be a way of saving and lowering the cost. But one of the downsides to that, it appears as though that the independent physicians seem to have become, like you said, a dinosaur. How does this bill help you and help other independent physicians?
Yeah. So from a very personal, I guess, self-interest standpoint, it allows patients to have greater access to come see me as their provider. When I worked down the street at the community health center, I had a tremendous number of patients that were enrolled in HMOs that had been seeing me for, I guess, going on 4 years when I started then, or actually a little over 4 years. That liked me. They expressed to me that, boy, if you leave the clinic, I want to follow you. I've left the clinic, not a single one has followed me. And what I've heard over and over is, well, my insurance, you're not in the network, and you don't take insurance. And so from a personal standpoint, it's affected me in the sense that it's severed the primary care relationship that was developed between me and my patients. These patients have all been left to now go reestablish with another provider, whether that's another physician or a nurse practitioner or a PA or whatever, but it's inconvenient to them and it's potentially dangerous. Somebody that doesn't know them well is more likely to potentially make a mistake in their care or overlook something in their care. So it has affected me in that sense. And then also it's affected me just in the sense that as a healthcare consumer, right now I'm in what I call an exclusive provider organization through Ambetter, which they don't so much have the same restriction because typically they don't require a referral to see a specialist, but the HMOs do, and so it's something that basically interferes with care. The only potential, I guess, benefit I see from the current system really only accrues to those who might have a financial interest in controlling the population. Senator Sherman, had brought up, an issue with hospital systems and restrictions they place. And, why would they want to do that? Is that in the interest of the patient, or is that in the interest of the hospital system and trying to coerce physicians to be a member of their system? and coerce patients to stay within their system. And the same thing with the HMOs. I could certainly see how, from their standpoint, if you look at it with a very cynical viewpoint, sure, it kind of does the same thing. It wants to try to wedge everybody into their network and into their system. It's anti-competitive. Beyond that, though, quite frankly, I feel like Senate Bill 97, quite frankly, has the potential to save these insurance companies money, in the sense that, if a patient comes and sees me and I send a referral, that patient goes and gets their referral. They go see the specialist in a timely fashion, rather than going and having a second appointment, which the insurance company is now having to pay for. So I think they actually stand to benefit financially, but more important, the patients benefit, the citizens as a whole benefit. Direct primary care, it's growing by leaps and bounds nationwide for a reason. It's certainly not the best fit for every single person out there, but for those who it is a good fit, it's a really good fit. And people, as they say, vote with their dollars and with their feet. And there's just a rapidly growing movement of physicians and patients going this route. And I think they should be allowed to do so with less restriction.
All right, I'm back. So thank you, Senator Gray. Further questions of Mr. McCready? Seeing none.
Thank you.
Next person I have is Eric Kropp.
Morning, can you hear me?
Good morning, Dr. Kropp.
Hello. Thank you, Mr. Chairman and Senators, for the opportunity to speak to this bill. I'm speaking today as President-elect of the New Hampshire Medical Society, and also as a family physician, specifically addressing Part 1, but the Medical Society does also support Part 2. Medical Society supports this bill, a bill which is going to preserve a patient's freedom to choose their healthcare provider, whether they put that trust in an independent direct primary care provider or a large regional medical center or a participating PCP. Patients should have the assurance that their provider can practice to the full extent and authority of their license, that those patients will receive the benefits that they expect from their health insurance when they need it most. The bill is of narrow scope, applying only to providers practicing in the direct primary care model, as was defined in HB 508, which is now in the RSAs. This is admittedly a small niche of the healthcare market. There are around half a dozen DPC practices in the state currently, growing dinosaurs, maybe we are. Representative Marsh described the problem. I'm going to expand a little bit on it. In the 5 years that I've been practicing in direct primary care, the majority of new patients who inquire to our practice and express interest, but ultimately decide not to join and establish care with us, cite this issue with insurance as the main reason why they don't join. It's easily more than half of the new patient inquiry phone calls that we receive that are affected by this issue. As you should understand, direct primary care patients don't use their insurance to pay for primary care, but they should carry a medical insurance plan. Those premiums are to guard against financial loss if they need to access other parts of the medical system, specialist consultations, advanced imaging, hospitalization, surgeries. In practice, this has worked well with direct primary care, but only for certain patients with certain insurance. Medicare patients, PPO plans, no referral plans, EPOs, and even Medicaid have mechanisms where direct primary care providers can practice to the full extent of their license and order and refer for medical services to those patients. Unfortunately, other plans, as have been described so far, do not. Even if you're referring somebody to a specialist who is in that healthcare network, those benefits may be denied, that specialist may not receive payment, and that patient may get stuck with that bill. So SB 97 is needed. Unfortunately, these types of policies are highly prevalent, and as Dr. McCready described, patients often do not have a choice. The purpose of this bill is to create parity between these different types of insurances so that there's not any discrimination against patients who can't afford or access these other plans, and so that thus patients can have an equal opportunity to choose a direct primary care provider for their primary care if they want to. What this bill does not do is it doesn't try to get away with the requirement for a referral. Or the need for these referrals to be medically appropriate. These referrals are important in general in the practice of medicine for care coordination, to make sure that patients are using resources appropriately, that we preserve access to specialists for those that need it most. What this bill does is instruct plans that they should apply their patients' benefits the same way, whether that referral comes from a network contracted PCP or a direct primary care provider. I hope that you'll please support this bill with the aim of preserving patients' rights to choose their physicians, to support access to this important alternative to the fee-for-service model, and to create parity among the different types of insurance plans and how they handle those orders and referrals by the licensed healthcare providers in our state. I appreciate your attention. I'm happy to entertain any questions at this time.
Thank you, Dr. Kropp. Are there questions? Okay, thank you very much.
Next up, I have Heidi Kroll.
Good morning, Mr. Chairman and members of the committee. Are you able to hear me?
Good morning, Heidi.
Great, thank you. Good morning. Yes, good morning, Mr. Chairman and members of the committee. For the record, my name is Heidi Kroll. I work at Gallagher, Callahan, and Gartrell, and I'm representing AHIP, America's Health Insurance Plans, which is the trade association for the health carriers. I'm here testifying on part 1 of SB 97, and AHIP is opposed to part 1. Our concern is that this bill is trying to give providers who are out of network the same benefits as being in network. So essentially the out of network direct primary care physicians are looking for the best of both worlds. And I will say that to the best of my knowledge, this type of legislation only exists in one other state. I think that Representative Marsh mentioned the state of Maine. AHIP is concerned about several potential unintended consequences if New Hampshire were to pass this bill. First, we are concerned that this bill will undermine the carrier's ability to build and maintain networks, especially primary care panels within networks, which will in turn erode the value of networks for New Hampshire's residents. As you know, providers that join networks typically agree to price concessions, which translate into lower premiums and lower costs for healthcare consumers. And in exchange for making the price concessions, the in-network PCPs are given the opportunity to care for the carrier's members, including making referrals and referring those members to in-network specialists. So if this bill were to pass, there would be really no benefit or advantage to being an in-network PCP. And the concern is that they would stop agreeing to price concessions. Of course, that would put upward pressure on premiums, copays, and deductibles for New Hampshire's citizens and employers. In addition, we are concerned that this bill could cause problems with patients' care management and lead to kind of fragmented care because you will be trying to manage a person's specialty care in network, but the PCP will be out of network. The final thing I would add is that, one of the challenges with direct primary care is that it is only a choice for consumers who can afford it, who can afford to pay out of pocket directly to the direct primary care physician. And we think it's just really important to be careful that that choice for some does not drive up the cost for everyone else. So for these reasons, AHIP is opposed to Part 1 of SB 97, and we would respectfully request that you find Part 1 inexpedient to legislate. I thank you for your time and consideration.
Are there questions of Ms. Kroll? Senator Gray.
I guess that, to me, there must be an alternative. If there was a review board that had to go through and check for these orders, if there was some other mechanism other than, the patient, having to go and have another appointment with another doctor, that from what it sounds like, just drives up the cost. Whereas maybe, some review board could look at the diagnostic evidence presented by the direct care provider. Are you guys willing to look at alternatives that, might find some middle ground between the two?
That's a great question, Senator Gray. I will go back to folks at AHIP and see if that has been used as a mechanism. I haven't heard that, but it's not to say that it hasn't happened. So I'm happy to take that question back. I don't have an answer for you here this morning.
Thank you.
I think we had Senator Avard, then Senator Sherman.
Thank you, Mr. Chair. Hi, Heidi. Thank you for your testimony. You had mentioned that it may erode networks, and that's like a buzzword for competition, which in my humble opinion may possibly lower the cost of care. It seems as though competition seems to work in that perspective. And the previous testimonies from the doctors said, it's a dinosaur. These private practices are really struggling, and I'm wondering, is competition a bad thing in this perspective?
No, thank you for that question. There's definitely a balancing act. So the issue with networks, and you may recall from several years ago when we first, I think if I'm remembering correctly, kind of the ACA was first launching, and we had the individual market, and there's a balance between, for example, a very narrow network where there are a very limited number of providers within the network. Was proven. We saw this several years ago when Anthem offered one or more narrow networks that really does lower costs because, as I said, there's kind of the relationship there where when you're in the network, the providers provide a price concession, and in exchange, they have access to the carrier's members, the opportunity to serve them. And certainly, there are network adequacy requirements. And I think perhaps you'll hear later this morning from Tyler Brannon, who is an expert on many things, but network adequacy is one. But certainly we have network adequacy requirements to ensure that people do have adequate choice within a network. And so there is, competition within the network. While still having the benefit of those price concessions. And of course, the network adequacy requirements also say that if a patient is not able to access the care they need in network, then they are allowed to go out of network. So there are, consumer protection provisions there. I think that, as I said, I think the thing to keep in mind with the direct primary care physicians is that, as you've heard, they are not participating with insurance. So people who go there obviously are making the choice to pay out of pocket, but none of those claims go through insurance. And so it's just a balancing act about making sure that the choice of those people, and I agree that, there should be choice. I agree with that. But we just need to be careful that they're not driving up the cost for everyone else using the network systems.
Senator Sherman.
So I have a kind of an interesting dilemma that you've brought up, Heidi, and I hope Tyler is listening as well. These people who have private insurance, commercial insurance, and have chosen to go to a direct primary care provider, of which I think currently there are really only 6 in the state. are actually saving you money because they're paying for their primary care themselves. And then you are saying, as the insurer, that they have to be seen by one of your practitioners. So that's additional cost to you and to your panel of customers, even though the cost that you have to cover for the appropriate lab is going to be the same. So essentially, your objection to this is driving them to having to have redundant care at an increased cost to you and to your panel. Am I correct there? So if this is a board certified or a physician who is under the direct supervision, or we're all accountable as a physician, all accountable to the Board of Medicine, are we not actually saving dollars by going to a direct primary care for all the people on your insurance panel? I would think they would have to order just a remarkable number of inappropriate tests to drive up your costs.
Thank you for the question, Senator Sherman. I think the issue is not that they are recommending tests and other procedures, services that are found to be not medically necessary. I don't think that's the issue. I think the issue really is more around the value of networks. And if you can, as a provider, if you can get all of the benefits of being an in-network provider and being out of network and still get those benefits and not have to give any of the price concessions, that's where the question and the concern comes.
Go ahead.
I have to admit, I don't really understand that answer. But I would think if I were
ask the question in a different way.
Yeah. Okay.
So
I can try to answer say it a different my answer differently. I'm sorry to interrupt.
So if I were to go to Senator Sherman as my physician and he was an out-of-network provider.
I would be honored, by the way, but I don't think you remember what I do for a living.
Oh, I remember. I'm of that age. But if I went to Senator Sherman and he was out of network, why would you not be able to reimburse Senator Sherman at the network provider rate that you establish within your network for your primary care physicians in your network? Wouldn't that be a reasonable compromise that would then allow for patient choice?
So I think that that's not what this bill is about. If I'm understanding correctly, this bill is not about paying an out-of-network direct primary care physician, paying them with insurance and what that reimbursement should be. Because my understanding is that direct primary care physicians don't accept insurance. That, as you've heard, they're making the choice not to be associated with insurance. And so anyone who goes to them just pays out of pocket, making that choice to pay out of pocket for the services, and whether they pay on a fee for service basis or they're paying some sort of monthly fee. I gather that there are different arrangements. So there's that issue, which I don't think this bill addresses. This bill is more, I think, dealing with the that direct primary care physician having these same benefits and privileges as an in-network PCP. And so, again, I think the issue is, like I said, we always, as carriers, we always work to try to make as robust and as inclusive a network as possible. But the arrangement is that, the provider comes into network, there's some price concessions given on their part. So they're offering their services for slightly reduced prices, and in exchange, they get the opportunity to serve the insurance company's members. And so if we take away the benefit to the in-network providers of having that kind of access to the members, and so they can be out of network, they can have all the benefits of being in network, but they don't have to make the price concessions. They're basically getting the best of both worlds. And I think the concern is that because we're no longer getting price concessions, the premiums and copays and deductibles, there will be upward pressure on those.
Right, but isn't the example that I used and what Senator Sherman said, if I as a patient am paying for my primary care physician, and my PPP, in this case, Senator Sherman, refers me to one of your members' specialists that are in network, and you're not paying Senator Sherman, why is that? I'm not sure why that's driving up prices, because the specialist is in your network and you're not paying for the out of network PPP.
I agree that there's the savings, that kind of initial savings, because you paid out of pocket for your primary care visit. But the issue is that over time, if PCPs say, forget it, there's no point in me joining a network. I don't have to give any price concessions. I can go out of network, still get all the benefits of making referrals. And so then the issue is that we don't, over time, our network gets eroded and we don't have the providers in network making price concessions in general. And so across services.
Okay.
I'm sorry, I can tell I'm not doing a good job of articulating it. Maybe others who follow me can explain it better.
All right.
I apologize.
Senator Avard, see if he can ask the question. Go ahead.
Thank you, Mr. Chair and Heidi. So if this puts pressure on the price concessions, isn't that the whole concept of competition? And if they want to do better, then they have to lower the prices so that the people stay within network.
I'm sorry, Senator Avard, could you say that one more time? I'm just trying to.
All right. Well, it seems as though it's narrowing the conversation to the price concession as the core problem here, that it'll erode that in some respect. So I'm wondering if that is not a good thing, because then that puts pressure on those to lower the prices rather than to increase them. It's more of a competition thing again. So. It seems as though you're saying that this is going to erode the price concessions. It'll make it non-effective, so people will say, "Hey, why stay in network?" Well, if that's the case, then the network needs to do a little better in lowering the prices, right?
Well, the price concession. So the carrier and the providers enter into negotiations, and I should mention that as there's the price negotiations piece, and then there's also the credentialing, right? So the other piece of and value of networks is that the providers that are allowed into the network have to be credentialed. They have to pass, high standards of patient care and quality and quality measures and that sort of thing. So obviously, if there's a provider out of network, the carrier at least has not kind of vetted the credentials of that provider. So there's the kind of patient care and safety that I just wanted to highlight. But, the negotiations between the carrier and the provider is that the benefit for the provider coming into the network is that they have the opportunity to serve all of the insurance companies' members who are in network. So they have that population that they're able to serve. And in exchange, they give price concessions. And so if they have the opportunity And there's obviously other benefits of being in network, referrals being one. So if they can have all of those benefits without giving the price concessions, that's where our concern is, that this could have upward pressure on premiums, copays, and deductibles. It's just a side of the ledger that needs to be considered at least. And as I mentioned, not everybody is going to have the financial wherewithal to have a direct primary care physician and pay out of pocket. And so we just need to balance the people who are making that choice with everyone else who's still using the network.
Senator Gray.
I want to go back to the question that I asked before after listening to all of this. If a direct primary care person says you need this, sends you off, and it has to do with price concessions, then if I go through some kind of review to say, yes, this doctor, has got the information that we need to make sure that the person needs it, and you charge that person a little more for that procedure, haven't I taken care of your problem? Haven't I gotten to a situation where now that extra amount you can distribute to however you want to the people that are in network and take care of the situation?
I'm sorry, Senator Gray, I didn't quite follow you. Where is this extra?
The person who needs the procedure,
Mhm.
if they pay, if you charge them a little more, 2%, 5%, whatever the appropriate amount is, somewhere around what that extra doctor visit that would actually do the referral is, then I don't see that I've done a whole lot different, except I've made it quicker and easier for that person to get the test that they needed.
Yeah, I mean, I guess I'm not quite sure I'm following you, but I do think that the other piece of this is that we do need to be careful, from the carrier's perspective. They don't know anything about the direct primary care physician or their credentials. And there does need to be that integrity around, making sure that the referral is for medically necessary services.
Follow up?
Yep.
Again, that's why I said that there would be some kind of a panel or a board or, specialist that would review the order from that doctor. And, much of what another physician in network would have done. And if they are charged a little bit more, then you have those funds to benefit the other people who were in the network. I think you can get there if you just.
I've made a note of that, and I will certainly take that back to AHIP. As I mentioned, to the best of our knowledge, this type of legislation is only in one other state. So, this is the whole field, I guess, of direct primary care and how that works with, insurance, kind of, insurance and networks and whatever. I think, we're still trying to sort that out. I think we just need to be careful about, like I said, careful about eroding the benefits of networks and making sure that the choice of some consumers who are going that route is not to the detriment of everyone else who is sticking with networks. So.
Senator Sherman.
Thank you. And Heidi, thank you for taking my question. I think you've said at least twice that one of the issues here is you don't know the provider, so you don't know that they are trusted in quality. And which to me is interesting because when, for example, I sit in Core Physicians, there's about 140 physicians in that. And I'm not sure the quality of each of us individually has been as much of a concern for the insurance carriers as much as what we are willing to accept for reimbursement. So it would seem to me, with only 6 direct primary care providers in the state, all of them are under the are accountable to the Board of Medicine. Wouldn't it make sense that number one, you're saving money because the customers on your panel you don't have to pay for their primary care. But if the issue is really one of the quality of the provider, wouldn't it make sense for the carriers to put in place a mechanism to say, well, yeah, you can order through the HMO or their insurance benefit, but we just want to make sure you meet certain criteria, one of which would be, you've got an MD or a DO and you are a recognized provider. In other words, if the major issue is quality, I think we really have those mechanisms in place, and you will be tracking their ordering practices anyway because you're paying for it. So I just wonder about the quality question that you've brought up a couple of times, and whether that is uniformly applied across all providers that are on your panels.
So I had mentioned quality simply to kind of remind folks about the value of networks, and that there's that kind of quality and patient safety aspect to it, as well as pricing. But I think the concern really here I think there probably could be, I agree, everybody is, accountable to the Board of Medicine, but nonetheless, carriers still go through their kind of, their own vetting and making sure that providers coming into the network have the right credentialing. But I really think that the main piece really is around kind of undermining and eroding the value of networks from the the pricing piece, and also the other piece that I had mentioned was the continuity of care, and not having a fragmented arrangement where the PCP is out of network and the specialists are in network.
Further question? Okay, Griffin, thank you.
Thank you very much.
Yep.
Second. Next person I have as one to speak is Sabrina Dunlap.
Good morning, Ms. Dunlap.
Hi, good morning. Thank you for bringing me over. I'm not sure if Tyler Brandon from the department speaking. I'm not sure if it makes more sense for him to go and speak to some of these sort of underlying issues you all have brought up. I'm happy to defer to him.
Okay, that sounds good.
Okay,
and we'll recognize you if you want to come back. All right,
Okay,
Griffin,
that'd be great.
why don't you go to Tyler?
Good morning, Tyler Brandon with the Insurance Department. And we don't have a position on the bill, which is typical, but we do have some concerns. And the more I think about this policy change, the more kind of complicated it starts to get. And there was a direct primary care study committee, and I actually wish the committee had explored kind of this policy change because of some of the implications and what it could mean, I guess, downstream. The more I think about it, just the more things come up. But I will kind of address both parts of the bill, starting with the direct primary care. And it's one of the reasons that we end up with a direct primary care provider at a network is because of an insurance consumer protection law. And that protection law says every in-network provider is prohibited from balance billing for beyond anything that is not regular cost sharing, your deductibles, your co-pays, things like that. So a monthly membership fee would be kind of a clear violation of an additional amount that's being billed beyond cost sharing, so that the system works best when these providers are out of network. But that lends itself to the challenge we have here, which is the direct primary care provider wanting to manage your care, do referrals, but not being a part of the insurer's network. When we clarified that direct primary care models were not insurance, we moved essentially oversight to the Board of Medicine, which is not routinely involved in administrative matters of practice. So there are a number of laws we've passed on the insurance side that are intended to protect consumers, but they're done through the insurance law and they're done through a provider contract standard with all of the providers that are in the network. Typically, the financial models under managed care have that primary care provider who is the gatekeeper, but they are responsible for managing all of your care at some level. So the cost for specialty care, which going back to this comparison of what you might pay a direct primary care provider versus a PCP, those amounts on either side are going to be insignificant when you compare it to the overall budget associated with a particular patient. So when we think about these products, I could see legislation like this being quite disruptive from kind of an administration point of view. So right now, many people who are under commercial insurance are required to choose an in-network PCP. I'm not sure how that design would function in the future if you had legislation like this. And remember, there's no relationship between a direct primary care provider that's out of network and the carrier. So any consumer protections, any expectations we put in insurance law don't exist because there is no relationship between the carrier and that particular provider. So, we expect healthcare providers to move away from a purely fee-for-service reimbursement system to try and live within some sort of global budget. But if you've got a direct primary care provider who's outside of that, they may not be as interested. So in fact, they may develop relationships with some of the most expensive providers in the state that would like to see all the referrals coming from those direct primary care providers. And so I think to the extent we're still stuck in a fee-for-service system, this change may actually create that inflationary pressure when you look at all the care that a particular patient is receiving. And going back to Senator Sherman's question about whether or not some of those requirements hospitals might put on a primary care provider in terms of referrals coming to that hospital, we actually have an insurance law that requires a PCP to give you a referral to somebody outside of the system the PCP works within. So if a hospital employs a PCP and the patient says, I want to go to some specialist that's outside of that, then the PCP has to give that patient the option. But that's a part of our insurance law. That's a part of that insurance requirement. So similarly, you could have a provider contract standard that says if a hospital is in network, they have to satisfy some of these options that would exist for patients. But to the extent legislation like this passes, you start to erode some of those consumer protections. And I could see a lot of kind of opportunities for providers to try and influence those direct primary care providers that are out of network. I think there are other potential downstream implications that it's hard to understand. I mean, even there are credentialing requirements on the books that expect insurance carriers to credential their in-network providers. There are NCQA requirements for insurance carriers to have certain credentialing standards for providers, as well as how care is managed. I'm not sure how legislation like this would implicate in those situations. But anyway, it's I guess I end up with more questions than maybe answers on this front, just because it would be a significant policy shift. So anyway, that's the DPC. I don't want to say too much about the PBM piece, except to the extent that the legislation changes RSA 402N, which is a PBM chapter. A little background, we being the insurance department, regulate PBMs when they work for insurance companies. And that's because we have insurance requirements that apply to pharmacy benefit type services. However, 402N, because of the way it defines a PBM, only applies to PBMs that actually service multiple insurance companies. So if it's a PBM that is servicing its new owner, and think that's the trend these days, large insurers buying their PBMs and doing work exclusively for them, then the new requirements wouldn't apply. So I think unless you want to create a double standard, and you probably do, you want to make sure that any new requirements would end up in both parts of the statute. It would restrict a PBM from prohibiting a retail pharmacy from mailing or delivering a prescription. PBMs use mail order for various reasons, but among them are access to lower priced drugs. So in the past, there has been some legislative interest in protecting independent pharmacies. And while this legislation might actually take a step in that direction and perhaps create a convenience for the patient, it may also result in higher prices paid by members and of course premium payers. So that should be a consideration with that change as well. And one of the other, going back to the direct primary care piece, and I kind of noted this as I was listening to testimony, one of the things carriers do to control the use of expensive services is prior authorization. If you no longer had a primary care provider that was in network, that was living under some sort of capitation or global budget, I could see one way a carrier would deal with that scenario would be to require prior authorization on a range of new services, because that's the only way they can really control access, or the only way they have some independent review of those services. And this goes back to Senator Gray's comment about, wouldn't it be appropriate for somebody to be reviewing these referrals? Well, prior authorization is one way that gets done, but it's seen as very inconvenient to both the provider community and in many cases the members. So this is maybe more of a brain dump than I would normally do during a testimony, but I just keep thinking about all these sort of new things that come up or new opportunities, but the complexity of this policy change is pretty significant. So I'm happy to take any questions.
Senator Whitley.
Thank you, Mr. Chair, and thank you, Tyler, for taking my question. So I'm just going back to your point about this eroding consumer protections, and I'm wondering if this bill could be amended to extend those consumer protections to make sure that these providers are covered under that.
The only way I could think to do that is you'd have to put those consumer protections into the license, the physician licensing side of the statutes, and you'd have the Board of Medicine making sure those consumer protections were followed. Because again, remember, the way we get to the provider's behavior today is through the insurance law, which creates a provider contract standard. So it's in the contract between the provider and the insurer. So without any of that, and as we did with the direct primary care language before, we put it under the Board of Medicine, but the Board of Medicine would obviously have to play a more active role on the administrative side of some of these practices, I think.
Senator Sherman.
Yeah, Tyler, again, I think you're painting a little bit of a potential doomsday scenario of this of the impact of 6 physicians in the state. But when you talk about creating an environment where you will start seeing steering of referrals and potentially inappropriate relationships, from my training, which we have to do every year on federal statute, kickback, all of those different statutes, don't federal statutes already exist that prohibit the kind of shenanigans that you are worried about occurring in inappropriate referrals between providers and labs and others?
I think you're referring to some of the self-referral laws or the Stark laws. Is that right? I mean, those would be certain prohibitions on physicians, for example, referring to entities that they have an investment interest in. Those laws actually apply to when the member is covered by one of those government programs, so Medicare and Medicaid. There are some interpretations of how it could apply under commercial insurance, but generally that's where those federal laws would apply. But I think we're talking kind of a much broader sort of contained within the system. And this goes back to your question. I mean, if a hospital wants to keep referrals, that is why they purchase so many primary care practices. So even if they don't purchase a direct primary care practice, the scenario I think you described, if I interpret it correctly, they are influencing primary care practices so that they get those referrals and the referrals come to the hospital system, so to speak.
Actually, if I could follow up, what I'm referring to are not as much Stark as because, that's often a self-interest, but also to anti-kickback. And I'm trying to remember there's at least 3 different federal statutes that involve very serious fines and prison time for violations. And we're all subject to that in the state. And I don't believe all of them are tied to accepting federal Medicare, Medicaid, especially Medicare. But I'll have to go back and look at that. But I'm just trying to be a realist here. The impact of these 6 providers trying to make sure that their patients aren't forced to pay twice or be inconvenienced twice. The insurance carriers actually do have a capacity to track labs by referring provider and also referrals by in-network referrals. And they could potentially, if the patient wants to get, does not want to pay out of pocket for those consultant referrals or specialty referrals, would they not have to stay in network for those? So it does preserve the network in my thinking, and it also allows continued insurance company oversight on utilization. Would you not agree with that?
So if I understand your question, you're basically asking whether or not, as long as you continue to go in network for those services you're referred for, lab specialist type services, you still wouldn't pay more than the regular cost share. And that's correct, right? Those providers have all signed a contract that says they won't balance bill the member for more. I think it has more to do with whether or not the patient's care is being adequately managed in a cost-effective way. And that goes back to what incentives does the primary care provider have? And it's not to say a direct primary care provider would necessarily not be part of an ACO, not be part of some collective global budget. But I think that at least in today's world, that shouldn't be assumed, particularly since there's no contract between a direct primary care provider and an insurer.
Tyler, we heard testimony from Ms. Kroll that Maine is the only other state to allow this. Is that your understanding of the situation?
I will admit I have not researched what other states have done, but I assume, Heidi, with their access to AHIP, they would know pretty well.
Okay, and do you have, talking department to department, any indication of how it is working in Maine, good, bad, or otherwise?
I don't. I can check, but I don't.
Okay. Are there further questions of Mr. Brannon? Okay, Griffin.
Yep. Thank you.
So I do have Sabrina Dunlap raising her hand, wanting to come back and speak. You okay with me bringing her in, Senator?
Yes, please. Thank you, Sabrina.
Hold on.
Thanks, Sabrina.
Yeah, thank you for bringing me back over and for the opportunity to speak. I'm Sabrina Dunlap, Director of Government Relations at Anthem. And I'd start by saying we are unaware of any sort of issues or barriers to care because of this referral issue that's been brought up. So we sort of question the necessity of this bill. But beyond that, we do have some concerns for our members as we see sort of more happening in the direct primary care space, and I think potential for confusion. And as you know, direct primary care is outside of the scope of the insurance regs and statutes and outside of the scope of the NHID. And some of you might know there was a bill in the House, HB 290. I'm not sure what the status is, but that would have taken direct primary care out from certain licensing requirements of facilities. And I mention this just to note that, direct primary care obviously sort of functions in its own realm. And I'm not sure that's always clear to patients. I think it could cause confusion about what they're actually signing up for and what is or not, what is covered with their direct primary care versus insurance. I think this gets to the sort of bigger picture, of the underlying concept of direct primary care. And I know that's not what this bill is about. But I do think all of these areas of concern are worthy of further discussion. And I would say we do share many of the concerns that, echo many of the concerns that Heidi brought up just around the concepts of managed care and sort of network erosion. So I hope these conversations continue. I think they're worthy of more discussion and just wanted to raise some of those concerns. So thanks very much.
Are there questions of Ms. Dunlap? Okay, thank you very much.
Next person I have up was Dave Rushford.
Good morning, Dave.
Me?
Yeah, good morning.
Hi, good morning. Thank you, Chairman and members of the committee. My name is Dave Rochefort. I'm owner and chief pharmacist of Eastern States Compounding Pharmacy here in Littleton. I'm also on the executive board of the New Hampshire Independent Pharmacy Association. Senator Hennessy pointed out, I'm also a board member of the New Hampshire Board of Pharmacy. I'm not speaking today on behalf of the Board of Pharmacy. I'm speaking on behalf of the fact that I'm an owner of a pharmacy here in northern New Hampshire. I really am here to talk about SB 97, the second part of it relative to pharmacy benefit managers, and asking for your support for that today. PBMs, other pharmacy benefit managers, known as PBMs, the meat of the bill is prohibiting community pharmacies from mailing prescriptions to their patients. So PBMs are the middlemen, as we know, in the prescription payment process, and they're ultimately the organizations that pharmacies such as mine and my colleagues here around the state contract with to provide local pharmacy services. It's been brought out already this morning that PBMs often own their own mail order pharmacies, and these such clauses that prohibit local pharmacies from mailing prescriptions to their patients, to their local patients, are very common in PBM contracts. For many years, pharmacy owners have recognized these clauses as being self-dealing. That's really what we look at them as being. But many of us have accepted them knowing that most of our customers are coming into our pharmacies to pick up their prescriptions in person. As we all know, as we're meeting here today in this format, many things have changed since COVID. These clauses have now become a potential public health issue and a barrier to access for prescription medications. And I say that as a potential because these, even with the COVID, these contracts are still contain these prohibitions for local pharmacies to mail prescriptions. So now if a pharmacy does mail a prescription to a patient who may be afraid or advised against coming out into a pharmacy, they're in jeopardy of severe consequences. These consequences could even include exclusion from the plan entirely, audits, having their contract canceled, and which doesn't seem right for people trying to help others during these times. One other thing I want to point out that this is not new. There is a bill very similar to this in Utah. Actually, I think the language came from that. I was told yesterday, although I have not confirmed it, that Arizona has something similar to this. But I want to highlight the point of this bill. The point of the bill isn't to allow retail pharmacies to operate as mail order pharmacies. We do know that there's a difference between retail and mail order. But what we're really looking for is we really want to ensure that retail pharmacies aren't classified as mail order pharmacies when they're just trying to serve vulnerable patients and continue care when they can't make it into a pharmacy. One thing I did look at, pulled out a contract last night, and at least one of the PBMs recognize in their contract the willingness to concede this if the state legislatures take action. And I'm just going to read that. So it essentially says right here, it prohibits, it classifies a retail pharmacy, does not include mailing prescriptions, other than on an incidental basis or as otherwise expressly permitted by applicable law. So obviously these, at least one PBM is willing to accept your authority on this and has put so in writing. So with that, I ask that you would support SB 97 and vote ought to pass, and I'd be happy to answer any questions that you might have.
Thank you, Mr. Rochford. Any questions? Senator Sherman.
Just a quick one. Tyler had brought up that we may need to make this change in 2 areas of statute. And I don't expect you to be absolutely, having memorized the statute, but would you be open to allowing that amendment if it were appropriate?
I think that, our group and myself, I'm speaking for our group as far as independent pharmacy owners, would be willing to do that. One of the things that we don't like is uncertainty. You look at some of these contracts and it says we may take action if you mail prescriptions, but again, we may not. You can mail some, but it's not defined what some means. So I think that our members are willing to eliminate the uncertainty that comes when we're just trying to provide services for our patients. So I think that's a fair agreement there.
I would just jump in, maybe if Tyler, if you're still on the line, if you could supply us that citation of the other section of statute that needs to be referenced. Okay, any further questions of Mr. Rochford? Okie doke.
Thank you.
Yep, thank you, sir.
Our next person up, we got Curtis Berry.
Good morning.
Good morning, Curtis.
Thank you, Mr. Chair, members of the committee. I am Curtis Barry here this morning on behalf of the Pharmaceutical Care Management Association, and speaking limited to Part 2. PCMA is the National Trade Association for the PBM industry, which is affected by Part 2. And I'd like to start by reminding the committee that one of the primary roles of a PBM is to reduce the cost of the prescription drug benefit for employers who pay the premium. That was referenced by Tyler in his comments. By saving money for the people who pay the premium, they may pass along savings to their members. These folks are often forgotten in these discussions. The language that you see before you in Part 2, as Mr. Rochford just indicated, is, I believe, word for word, what is on the books in Utah. And as he mentioned, there is another statute in Arizona. You should have received a hard copy of testimony from PCMA, Mr. Sam Hallemeyer from PCMA last night. And at the end of that, you'll see the full text of the Arizona provision. So regarding this part, we have really 3 comments. The first one, I think, is segues from Mr. Rochford's comments just now. First of all, we're aware of no member, we surveyed members that are restricting pharmacies from mailing or providing delivery. In fact, the prescription center here in Concord, one of my pharmacies, has been providing delivery service for many, many, many years, since I remember probably in childhood. But what this provision would do, this first one in Part 2, 1A, is really allow for a de facto mail order pharmacy with being treated as a retail pharmacy for reimbursement purposes. The reimbursement rates are higher for retail pharmacies, and that's how the costs could go up. So we would look for language similar to what Arizona has, which is provided in the testimony, somehow limiting. Arizona uses the word limited, the limited delivery of prescription drugs by mail or common carrier to a patient. The second point I'd like to make is there aren't any provisions around confirming that the patient has received the package or the prescription. Now, states, and we're all more lenient in the current pandemic for good reason, for health reasons, but we shouldn't put in statute and make those practices permanent. We think there should be some method to confirm that the patient received the prescription. And then lastly, Part 2B, the issue here is the statute would allow, in essence, the retail pharmacy, when making a delivery or sending by mail, to charge the patient. What we'd ask for is similar language that's in Arizona under letter C, that the patient is aware that any fee may not be reimbursable by the plan sponsor or the pharmacy benefit manager. Again, we're not aware that this is a current problem that's happening in the state of New Hampshire. Had discussions with proponents of the bill. Happy to continue to do so to work out language relative to these concerns, and I'm happy to answer questions. Thank you very much.
Thank you very much, Curtis. Are there questions of Mr. Barry? No questions. All right. Griffin, is Curtis the last person?
The only person, we've gone through the entire sign-up list. The only person we have left wanting to speak a second time is Samuel McCready.
Okay, before we get to Mr. McCready, what I would suggest, Curtis, is if you could work with Senator Hennessy on part 2. I think all 3 points that you made, maybe somebody would disagree with me, but they all seem to be reasonable. If you could work on language with her to, be self-limiting, make sure that the patient receives the prescription and is aware that a delivery fee may not be reimbursable.
Very happy to. Thank you.
Okay. Okay, go ahead, Griff.
Bring in Sam McCready.
Good morning again, Dr. McCready.
Good morning, and thank you for allowing me to speak again. I just wanted to very briefly touch on some of the points that were made in Ms. Kroll's testimony, because some of the things that I think are issues that are not exactly accurate as she presented it. She repeatedly said that direct primary care providers are trying to have the best of both worlds by getting all of the benefits of being an in-network provider without having to make any of the price concession for physician fees that the in-network providers make. The only real benefit as a physician, the only substantial benefit for being in-network is my ability to bill the insurance company and get paid money. I'm not getting that benefit as a direct primary care provider because I'm not billing the insurance at all. The concession she talks about, by default, my concession to the HMO is better than anybody else's because it's zero. My physician fee that the HMO pays me is zero. I will beat any other provider in the state who's in network on that. As far as the comment Senator Gray brought up about having some sort of a mechanism for reviewing the orders to make sure that they're not inappropriate and such, that exists. It's utilization review management. And in subsection 4 of part 1 of SB 97, it specifically addresses that. The wording here I'm reading, it says, payments may be subject to utilization review by the insurer if they would have been subject to such review if ordered by an in-network provider. So there already is a mechanism in place. A few months ago, when I was working as an employee physician, I was an in-network provider. And yeah, I mean, every order I gave that went through that, it got utilization review. It was all the prior authorization, all that kind of stuff. And this bill specifically says, hey, that stuff can still exist. The insurance company has a right to look at that order and say, hey, we're going to approve that or not based on medical necessity and appropriateness. And so this bill already addresses that issue. The other issue that came up was one of credentialing, and Senator Sherman kind of talked about this as far as being a large group and stuff, and are the individual doctors really being looked at that closely? The reality is that, yeah, a few months ago, I was an in-network provider. Nothing's changed. I'm still a board certified physician, still subject to all the same requirements from the state licensing board and from my medical specialty board as far as maintaining, continuing the medical education and all the same, basically all the same requirements. Beyond that, there is what's called the CAQH, which is a website where physicians all around the country have all of their credentials continuously updated, showing their active licenses and such. Every quarter, you have to go in there and make a reattestation. As an employed physician, my employer did that. As a self-employed person, I'm doing that myself. I actually did that about a week ago, where I went in and updated all of my credentialing stuff. And that's publicly available to any insurance company that wants to take a look at that. And then the other point that was brought up was one of fragmentation of care. And the reality is that as a primary care provider, that's what I do. I help manage care and I follow my patients. I make a referral to the cardiologist. I don't talk to the insurance company about that patient's care. I talk to the cardiologist, and the cardiologist talks to me. The only fragmentation is basically getting the insurance company out of my medical decision making. And so really, I think these are all kind of specious points that were being made by Ms. Kroll. This bill basically all it does is it gives patients a little bit more freedom of choice, saves them time and saves them money. And ultimately it also saves money to the HMO because they're not paying me a dime and they're not having to pay for that second appointment. As a direct primary care provider, a patient can come see me on a Saturday or give me a call on a Sunday if they need to, and potentially save them going to the emergency room, which the HMO is going to pay a huge fee for that. And those are real world examples. So that's not something I'm just making up. And so ultimately, yeah, this is really about control. Are we going to allow HMOs to control the patient population and to control the providers? And I think that this bill addresses things in a fair fashion. It still allows the insurance companies to do all their utilization review. It allows them to make sure people are properly credentialed, all of those things. It just gives patients an option to say, hey, this is the person I want to be my doctor and to be my primary care provider.
Are there further questions of Dr. McCready? Okay, seeing none. Is there anybody that has not spoken on Senate Bill 97 that wishes to speak at this time? Please raise your hand.
The only other person I see with the raised hand is Richard Cohen, wanted to speak for a second time.
Okay, very well, very briefly though, please.
It will be very briefly, Senator Bradley. Regarding Curtis Barry's statements regarding mail order, confirmation of mail orders, mail order companies, do they have to have confirmation of their mails? I mean, we would do the same thing as a mail order company. So I disagree with his concern about that. Also limiting mail order. I said, this again is just another ploy by PCMA for keeping their thumbs on the community pharmacist necks, controlling free enterprise. Thank you.
Okay, any questions? Thank you very much, sir.
I see no other hands raised at this time, Senator.
All right, let's close the hearing on Senate Bill 97 and the time being 11:22. Somebody would make a motion to go into executive session.
So moved.
Boy, everybody raised their hand. So I got Senator Gray made the motion, Senator Whitley seconded. I will call the roll. Senator Avard.
Yes.
Senator Whitley.
Yes.
Senator Gray.
Yes.
Senator Sherman.
Yes.
And I vote yes too. All right, so first things first, let me give a summary of the bills that we have in committee. We have Senator Gaida's bill that deals with high concentration marijuana. If you recall, we gave Senator Gaida a little bit of time to go to the Cannabis Oversight Board. My understanding is that meeting is occurring this afternoon, so hopefully by next week we can discuss that. Senator Sherman's bill, Senator Sherman indicated, this is the advanced directives bill, that he had a excellent meeting with all of the participants. As you recall, last week there were a lot of people that testified on that bill.
We had 25 in attendance, so it was good. And
together and is making progress. Go ahead.
I was just going to give the update that I think we're making progress, and we will have a second meeting next Tuesday from 3:30 to 5, hopefully to get through the remainder of the bill.
And that would be excellent. And then Senator Prentice's bill, Senate Bill 75. There was testimony about the potential of a non-legislative solution. I have not spoken with Senator Prentice about the progress that she may or may not be making, but I think we indicated we would give her time for a non-legislative solution. Those are the three bills that we have not taken action on. We do have 3 bills scheduled for next week. I'll get to them in a moment. So then we have the 2 other bills, the bill that we heard today, Senator Whitley's bill, and Senate Bill 97, Senator Hennessy's bill. So if I'd entertain a motion on Senator Whitley's bill, and then we can discuss it. Senator Sherman.
I move ought to pass.
And is there a second? All right. Who wants to start with discussion?
I'm sorry, Senator, who was the second on that
Oh,
motion?
I'm sorry, Senator Whitley.
Sorry, got it.
Senator Sherman, Senator Whitley, or do you want me to do the discussing?
No, I can start out. This sounds like a win. You know, the only concern is where do we get the $150,000 from? But it sounds like the $150,000 is an awesome investment in, you know, both the people who are in need, so it would go directly and in an accountable way to people who need the assistance. As a physician, and especially in digestive diseases, I was heartened to hear the impact on celiac in the testimony, and hopefully we are all aware, as the nutritionist who spoke said, this is not just an investment financially, it's an investment in the health of families in New Hampshire. We know that nutritional insufficiency can really decrease a child's success in school. It can decrease a family's success as a unit. But I think it also gets at, you know, how are we responding to COVID? How are we making sure our small businesses and farmers are intact? And again, this is a big investment in them too. So I think $150,000 in New Hampshire is a lot of money. But it is, you know, we have spent millions of dollars over the last year on supporting businesses in need during COVID. And I think this could fall under the same rubric. And with the return on investment of $150,000 to end up with $300,000 with federal match is a major win. So I think this meets all of the it actually exceeds what I would say is a high bar for how we invest our New Hampshire dollars, and I would be fully in support of it.
Senator Whitley.
Yeah, thanks for that. I agree. I actually think it's not a huge investment. It is a minor investment considering the benefits that we will get all around. The health benefits, you know, of course, will save. You know, if we're addressing children's health, that's going to, you know, save costs down the road. I mean, that's a win-win on the health side, you know, making sure that our small businesses who are really struggling right now with the pandemic, you know, they feel that support. You know, these farmers markets and the small grocers are huge economic drivers. I know in my district, you know, which has some rural communities, they are huge economic drivers in the community. They bring people, you know, to our communities. Both to shop and then they shop at other businesses is a big economic driver. Also, this opportunity to get additional federal dollars to support hungry families seems like a no-brainer to me. So I would appreciate everyone's support.
Okay, so let me chime in here. I'm going to support the bill. I was struck by the fact that over 200, almost 225,000. No, I think exactly $225,000 of private funds were raised for this. That shows a program that works with private funding. I think some small amount of general fund matched by federal dollars. How far it goes, I think if it becomes popular, is a question that remains to be seen. So I'm gonna support it, but I think we also have to understand, how this will work. It will have to, be included in a budget. So most likely, Senator Whitley, if the Senate chooses to go along with, the recommendation of this committee, assuming, Senator Avard and Gray go along with it, it would be likely to go to finance and be tabled for consideration in the budget with many different priorities. But I think the case was made, the department, spoke highly in favor of it, even though their official position on the bill was neutral. So I don't see any reason that we shouldn't at least give it our initial blessing, and that's what this would be. Anyone else? Okay, Senator Sherman has moved, ought to pass. Senator Whitley has seconded. I will call the roll. Senator Avard.
Yes.
Senator Whitley.
Yes.
Senator Gray.
Yes.
Senator Sherman.
Yes.
And I vote yes. I think this would do very well on the consent calendar. Anybody want to move that? Senator Avard moves consent, seconded by Senator Gray. I'll call the roll again. We'll start at the top of my screen. Senator Sherman.
Yes.
Senator Gray.
Yes.
Senator Whitley.
Yes.
Senator Avard.
Yes.
And I vote yes. So it'll be on consent, and Senator Whitley can do the honors. Okay, so Senate Bill 98. This is a pretty interesting bill. I think there's a lot of merit to part one. I think I would, oh, I'm sorry.
98?
I said 98, I meant 97. A lot of merit to part one, a lot of questions about part one. Part two, fewer questions. I think the language that, Curtis is suggesting does not harm the bill. And I think, as I said earlier, if he were to work with Senator Hennessy, that would be helpful. So in terms of part one, there are several different options that I see. We can hold the bill, continue to work on part one. I think there are a lot of questions that have been raised, so there's a couple of options. We could refer the bill and continue to look at it over the course of time. We could limit it so it would effectively become a pilot program if it were sunset in 3 years or 5 years. That would be an option too. I don't think we need to take action on it today, especially if part two is going to have an amendment. The one thing, and I think I'll get to discussion in a minute, but Senator Sherman and Whitley, if you bring up in your caucuses today, I'll bring it up in our caucus today. This is not going to be unique to Senate Bill 97, where it could be that one part the committee wants to re-refer it, and the second part the committee wants to pass it. Procedurally, we've got to figure out how to do that, and I don't know that that's been discussed since, quite frankly, we're just getting into hearings on the omnibus bills. So that is a open question. Not that, re-referral is what we're eventually going to do, but it's one option. Senator Sherman.
So the problem I have with re-referral is that if we do nothing while we re-refer, I'm not sure how we're going to resolve the concerns raised by the department and by AHIP without getting some data. And that's why I like the idea of a 5-year, 3 or 5 year authorization with a reauthorization at the end of it, because then you have data and you can look at that data and say, this is going the wrong direction. Heidi's predictions are coming true, and this is driving up insurance costs. Or there are utilization concerns, or all of the different things that they cited as sort of the doomsday outcome. On the other hand, if you don't allow it to move forward, we still have the same problem that Representative Marsh and Senator Hennessy, I believe, brought up and brought the bill forward with. So I would favor gathering the data as a pilot program. I frankly don't see direct primary care going wild and taking over the practice of medicine in the state. So I think it will naturally self-limit, and we'll have more data. The only question I have on that is if we had a very effective commission on direct primary care, and I served on that. Representative Marsh was the chair, and it was nimble. And whether we need to have that kind of mechanism, and in fact, Tyler was a part of that, whether we need to reconstitute that commission at the end of 5 years or at 4 years to look at the data and make a recommendation. So I would vote a 5-year pilot project and get the data. And then the only question I have is who looks at that data and comes up with recommendations to the legislature on whether or not to reauthorize.
Senator Whitley.
Yeah, I think, I like this idea of the either 3 to 5 year sort of pilot, look to reauthorize, but I actually like that addition of someone, a more formal mechanism to look at the implications on the network, and want to make sure that it includes, folks like, patient advocates and insurance providers. So just includes everyone, New Futures, Lucy Hodder, all those folks. I think that would be a good idea. So I would be supportive of this 3 to 5 year. I don't, the question is, would we get enough data in 3 years, or do we actually need 5 years?
All right. So here's what I'm going to suggest. I mean, I think there are a lot of questions. And Senator Avard.
Thank you.
I love on my screen. I can't see your face for your guitars sometimes.
Okay, there it is.
There you go.
I wanted to ditto their comments. I love listening to Tyler, but he said potential downstream concerns, and the only way you can get to the downstream is if you get in the river. So I'd say a pilot program as well. And access data. I love listening to him talk because he's a great communicator. But I think we should let that boat sail for a few years and find out how effective it is or non-effective. So I would agree.
All right. So what I was going to suggest is if we're tasking Senator Hennessy with part 2. I'm not sure we should exec this bill today. In any case, I think that folks on both sides of this debate, I encourage you to, contact all of us directly on the idea of, basically a pilot program on part 1. It seems to have at least 3 members supporting it, and since I was the one that broached it, I guess I would say 4 members are somewhat favorable to it. So for folks out on the virtual audience, please contact all of us individually. We won't take it up then today, and we'll probably let it wait until after the 18th in any case. It doesn't have No, it does not have a fiscal note. So everybody has a little bit of time. Is everybody okay with that? Senator Sherman.
Can we ask the prime sponsor and maybe Representative Marsh, who's been very involved in this, to help with drafting an amendment that would do that?
On part 2 or part 1?
Part 1.
Absolutely.
Senator Hennessy and Representative Marsh do not appear on the attendees list, but I'm sure Senator Bradley, you might mention it to her whenever you guys see each other, or I can shoot her an email and let her know.
Yeah, go ahead, do both. We'll
Okay.
mention it to her this afternoon.
I always think it's appropriate to volunteer people who are not present.
Well, I'll do that to you pretty soon. then,
Right,
Senator
you can come
Schumer.
back around there, Tom.
Yeah.
I will never miss a meeting.
He said never.
Okay, so let me ask a question of everybody. We have 3 bills that have been assigned to the committee for next week. Griffin, can you remind me again what they are? 120, 21, 123.
Senate Bill 120, 121, and 123.
And the subject matter again.
Oh, yeah,
I'm
sorry. Senate Bill 120 is Senator Sherman's bill relative to physician assistant medical services through the Manchester VA Medical Center. Senate Bill 121 relative to a state-based health exchange, primed by Senator Rosenwald. And then Senate Bill 123 relative to co-payments for COVID-19 testing, and that is primed by Senator Sherman.
Tom, on 120 and 123, how much time would you anticipate a hearing?
120 may have a few people testifying, but I don't think it's terribly contentious. So,
okay.
Because I know the PAs will want to testify, and then 123 is, just making sure that COVID relief is extended to people with testing, so that might take a little bit longer.
All right. So given, we have a morning Zoom and it's on Wednesday and it's before session, what would the committee think? And can we even do this, Griffin, if we were to start at 8 or 8:30 with our Zoom licenses? Or is that frowned upon?
I am certainly not in. I'm certainly not Josh. So I think I don't envision an 8:30 start time, or 8 o'clock would be terrible. I mean, we've done it before with committees in the actual building, but yeah, I can check with Josh and get back to you on that.
All right. Does anybody have a problem with an 8:30 start to give us a little bit more
That sounds great.
flexibility? Okay, then let's plan on 8:30. Jim?
I'll turn my camera off while I eat my Cheerios.
I can have my 7-year-old call at 6 o'clock to wake you up, Senator, if you want that. He's my alarm clock.
Okay, we'll shoot for 8:30, see how that works. That'll allow me to put at least, if we have more bills, at least one more on for the docket for next week. And we'll go from there. Okay. All right. Motion to adjourn.
So moved.
I think you need a
Move
motion to come out of executive session.
Oh, yeah, Gray, you're always catching me in that. You're like a hawk. All right,
Oh.
Senator Gray moves that we leave executive session, seconded by Senator Avard.
Okay.
All right, we'll call the roll, starting with Senator Sherman.
Yes.
Senator Gray,
Yes.
Senator Whitley,
Yes.
Senator Avard,
Yes.
and I vote yes. And now a motion to adjourn. Senator Gray moves, Senator Sherman seconds, Senator Avard,
Yes.
Senator Whitley,
Yes.
Senator Gray,
Yes.
Senator Sherman,
Yes.
and I vote yes. Okay. See you all at 8:30 next week
Yep.
and
Thank you.
tomorrow.